there's a new study that's looking at the potential positive aspects too.
So what were you going to do with this big cabinet?
Possible thanks to this really unique situation that arose from the COVID-19 pandemic, where between 2020 and 2022, I'm sure you remember, games consoles were in really short supply. And so in parts of Japan, they put in place a lottery to determine who was able to purchase a games console. So this was a kind of random trial that happened out of this situation. Now, a research team has managed to survey over 8,000 people who participated in this lottery. Some of them got games consoles and some of them didn't. And they asked all of these people questions about their gaming habits and also their well-being. And what they found was a link between those people who were able to play games and having a slightly higher well-being, suggesting that actually there were positive effects of playing video games.
Is this benefit
negative effects as well? People think that first shooter is reality.
In this study, they did see that it seemed to plateau at around 3 hours a day, which seems like quite a lot, but maybe that's
3 hours a day.
More than 3 hours a day.
The first shooter for a video game?
You in some way or another, because maybe you're spending all your time
play the game
rather than doing
console.
something else. But one of the interesting things here is we don't quite know what the
Now, if it was an old system, I can understand because you had to wait a few minutes for the shit to load.
But it could be things like just playing games is generally fun. Some of them have a social element. There's also
I know what I missed.
some element of testing your brain. All of that could be linked to positive well-being.
And does a study like this have anything to tell us about current concerns over screen time for kids? You know, if video games turned out to not be so bad, would the same end up being true for cell phone access or social media?
I think we're increasingly seeing that this conversation has to be nuanced. With screen time, it's of course the case that you can have a screen time habit that is unhealthy.
Let's go get that cabinet,
There are
baby.
also so many positives that can come from screen time too. You have access to a huge amount of information. It can be a social device. And so all of those things have to factor into it. It's very unlikely, I think, that even with infinite amounts of research, we're going to conclude that screens or video games are entirely good or entirely bad. And so I think this is another piece of evidence that nuance is what will be required.
Well, that's all the time that we have for today. I'd like to thank my guest, Tim Revel, Executive Editor at New Scientist, based in London, England. Thanks for joining us.
Thanks for having me.
We have to take a break, and when we come back, getting an IUD can hurt a lot. The CDC has finally put out pain management guidelines for this method of birth control. Stay with us. This is Science Friday from WNYC Studios.
Support comes from Betty Ford Alpine Gardens with a new exhibit that helps explain the direct line from dinosaurs to modern-day birds. The exhibit and the gardens are open every day, dawn till dusk, in Vail. BettyFordAlpineGardens.org.
You know those commercials with women wearing sleek, shiny, bouncy hair? It's a look that's more attainable for some than others.
How can I maintain this look? How can I continue to catch up with it? I felt like there was a carrot that was being dangled in front of me that I could never catch.
This week on Real Talk with Denver 7 CPR News, Black and brown people with textured hair and their complex journeys to having pride in their natural coils. This afternoon at 3:30 on CPR News and KRCC.
This is Science Friday. I'm Maggie Kern. Last week, the CDC announced updated guidelines for managing pain by inserting an IUD or intrauterine device. This is a little piece of plastic that doctors can insert into a uterus to help prevent pregnancy. The recommendations now advise doctors to consider using local anesthetics like lidocaine to help manage patients' pain. There's been an outpouring of patients in recent years speaking out about just how painful their IUD insertions have been, and that their doctors didn't provide anything that helped mitigate their pain at all. In some cases, the doctors even dismissed their experiences altogether. Joining me now to discuss the significance of these new guidelines is my guest, Dr. Beverly Gray, Associate Professor of Obstetrics and Gynecology at Duke University, based in Durham, North Carolina.
Thanks for having me.
Thank you so much for being here. What was your reaction to these updated guidelines? How much of a difference is this actually going to make for patients?
I was excited to see the updated guidelines because it's definitely an important conversation that's happening in the public right now. And amongst physicians as well, focusing on patient-centered care is always necessary. You know, one important thing to note is that in 2016, the CDC actually put out some guidelines recommending that doctors talk to their patients about using lidocaine injections for pain control. And these updated guidelines simply add more evidence to support that, as well as topical lidocaine or numbing medication on the cervix as well.
I think there's probably some people who are not familiar with IUDs or just don't even really know what this is. Where does the pain aspect come from when you're talking about inserting an IUD? Can you just kind of describe a little bit about the process of this and like why it might be a painful thing for people?
So like you mentioned before, IUDs are placed inside the uterus, and to get inside the uterus, you first have to do a pelvic exam, expose the cervix. For some people, just that speculum exam or pelvic exam is uncomfortable. Then you use an instrument to steady the cervix. You measure how long the uterus is, because the IUD is more effective if it's right at the top of the lining of the uterus. So you want to have a good measurement of that. So the measuring can be uncomfortable. And then the IUD is loaded in this little tube, and that tube goes inside the uterus, and then the IUD opens once it's inside the uterus to fit the shape of the uterus. You know, this process typically only takes a couple of minutes, but to navigate through the cervix, that can be uncomfortable. To place the IUD, that can be uncomfortable. And to place that instrument to steady the cervix, that can also be uncomfortable. And we know that there are certain factors that influence who has a worse pain experience. So we know that people who have never had a child before, or who have never had a vaginal delivery before, tend to have more pain. We know that people with anxiety or history of trauma or sexual trauma may have more pain. And anxiety is a risk factor for pain with a whole host of different types of procedures in medicine. So there's a lot of research to support that if people have anxiety, or particularly anxiety about a procedure, it can impact their pain experience. So we know that all of those factors can influence pain at any one of those steps. But even with all that said, it's really hard to predict who be like, okay, no big deal, that was not as bad as I thought. And then who might have a really difficult experience, even if they have protective factors to protect them from pain.
So the guidelines specifically mention lidocaine as an option for pain management. How effective is that, and how is that administered? You're talking about an injection in that case, right?
So there are two options for how you can administer lidocaine. So one way is either a paracervical or intracervical block. And so the cervix is the opening of the uterus, that part that you have to navigate through to get the IUD in. And there are these nerves that pass near the cervix. And so if you can inject numbing medicine right near those spots, sort of, you know, similar, like if you have dental work, you inject near the nerves where the pain is going to be. You know, there are mixed studies like showing some positive effects of lidocaine, some not showing positive effects necessarily, but the breadth of research would support using numbing medicine injection, especially for patients who have never had a child before. The new guidelines also include using topical numbing medications or lidocaine, and that can numb the surface of the cervix where you're placing that instrument. And it may or may not help with the actual insertion of the IUD, but some people don't want an injection right beside their cervix.
You kind of talked a little bit about how anxiety and the fear anticipation can actually influence the amount of pain that people feel. Do we know anything about why that happens? And also, you know, is that anticipation of pain dissuading people from getting IUDs who might benefit from it?
You know, I don't know the exact mechanism, although I do know that across studies, anxiety and sort of heightened apprehension or anticipation of a procedure can impact pain. You know, I think sometimes having just open, frank conversations with patients so that they're not feeling like their concerns are being minimized. We've seen so many stories of people who have a very difficult traumatic experience with their IUD insertion, and I'm sure that is absolutely influencing people's decisions about whether or not they want this form of contraception. And so when you go to your doctor and your doctor's like, oh, it's no big deal, after you kind of talk with patients about kind of the spectrum of experiences, knowing that the vast majority of people have a very tolerable experience with their IUD insertion, and that there are a subset of people who have a difficult experience, I think when you have that conversation, you go through the options for pain management, and you have shared decision making, I think patients feel more control and more ease. And there are some patients who come in very concerned about having it placed, but really wanting an IUD placed. And sometimes the shared decision making is to decide to place the IUD under sedation or in an operating room setting. And I do think that concerns about pain are hindering people from choosing this as an option.
How common is it to be in severe pain in these kind of situations? You know, I know that I had an IUD. I barely noticed it going in, but I have friends who've had discomfort. I've had friends who've had severe pain. Do we have like any data on how common one response is versus another?
I think rates are kind of around 20%. I think it probably varies by provider experience and practice and whether or not they're routinely offering pain medication in their counseling. Yeah, I would say in my own practice, I would say it's probably less than 10%. And so it's more rare that we see that, and it's more common that we see patients have a really good experience or better than they expected experience. You know, what's interesting is that if you look at physicians and OBGYNs and what they choose for contraception, a much higher percentage of them choose IUDs, and these are folks that are placing them every day in their practice and seeing what patients' experiences are like, and also seeing the other side of it too. So there are a lot of positive side effects from IUDs. So for people with hormonal IUDs, it can stop their menstrual cycles. It can make their menstrual cycles much less painful. You know, for myself, I love my IUD, and I have migraines with aura, so I can't use estrogen-based methods. So for me, it is the best method.
Gynecology has this long history of dismissing women's pain. Do you see these updated guidelines as a signal that something like that is changing, that we're going to see a better future where medicine is respecting and meeting women's needs?
In our own practice, in our own training, and I will say kind of at our institution, I have seen a transformation from my training to now, and I think having these conversations are so important. I think not dismissing patients' pain and calling women hysterical, like that's not the legacy of medicine that we want. And you're right, I think OBGYN has some negative things in our history and our past, and I think the hopeful thing is that this generation of doctors is changing the practice of medicine. We're making good advances, and I think listening to patients is key to that.
That's just about all the time we have for today. Dr. Gray, thank you so much for taking the time to talk with me.
Absolutely, thanks for having me.
Dr. Beverly Gray is an associate professor of obstetrics and gynecology at Duke University, based in Durham, North Carolina. Sequoia National Park in California is known for, sequoias. Big, beautiful trees, some thought to be thousands of years old. But severe wildfires fueled by climate change and fire suppression have destroyed some of those trees. One solution is to plant new sequoias, but this creates an interesting scientific debate. You see, most of Sequoia National Park is designated as wilderness. It's meant to be untouched by human hands, and some people argue that means humans shouldn't intervene, even when that land is changing because of human behavior. My next guest has a new podcast that explores this story and others in a quest to better understand the meaning of the word wilderness. Marissa Ortega-Welch, host and producer of the How Wild podcast from KALW and NPR in San Francisco, California. Welcome to Science Friday.
Hi, thanks for having me.
Okay, so before we dive into this controversy around Sequoia National Park, let's back up and talk a little about the importance of the word wilderness in this context. What is a capital W wilderness?
Right, so you may have an image in your head when you think of the word wilderness, but the U.S. has these designated wilderness areas. These are places within national parks, forests, or other federal public lands that have this extra level of protection. So if you can picture Yosemite Valley, if you've been there or seen photos, the area is beautiful and iconic, and it is protected by the national park, but that's not designated wilderness.
you'd have to head out on a trail away from the roads of the valley, and after a couple miles, you'd enter into a designated wilderness zone. And these zones are governed by a law. It's the 1964 Wilderness Act that says these areas have to be managed for certain conditions. So they have to be undeveloped, roadless, but also they have to be natural and untrammeled. And untrammeled is kind of this old-timey word that means unrestrained or free. A lot of people hear untrampled, but it's a little different. This means that in this context, humans shouldn't control what happens in wilderness, and nature should just be allowed to take its course.
Is anything really untouched in the wilderness, though, still? I mean, human-made climate change is affecting just about everything.
Right. Every part of the planet is affected by climate change, sadly, even wilderness. So just like outside wilderness, inside wilderness, we're seeing longer periods of higher temperatures, we're seeing drought conditions, snow melting faster, extreme weather events. All of this is contributing to the more severe fires in wilderness areas that we're seeing in the West and across the country. So within that meaning of wilderness, under the Wilderness Act, these areas are supposed to be quote-unquote natural, but climate change and other human-caused factors are making that challenging.
So let's get into the story you've reported at Sequoia National Park specifically. What has happened there with the trees, with the wildfires?
Right, so since 2020, Sequoia National Park has had these really severe fires that are killing off sequoia trees. And it is a combination of climate change and a phrase I've learned that's called fire exclusion. That means that fire has been kept off the land, and this has been happening for more than 100 years. First, by the displacement of indigenous peoples who actively burned the land as a management practice, and then through the suppression of fires by the Park Service. And what happens when you suppress fire is that the forest understory grows, the duff on the forest floor builds up, and then with climate change creating these hotter, drier conditions, all of the forest understory is just like dried kindling waiting for a match. So the fires they've seen in Sequoia National Park for the last couple of years have been incredibly severe, and they're burning and killing these giant sequoias, which is saying something because these trees are actually built to withstand fire. They have this thick bark that makes them fire resilient, and they depend on the heat from the fire to help them reproduce. It triggers their cones to open and drop seeds. So this is saying a lot that we're losing these trees, and some scientists are concerned that we could see a Sequoia National Park with no giant sequoias.
Wow, that is sad. You talk to scientists, though, who want to intervene, and they want to plant new sequoias. What did you hear from them? What's their plan like?
Yeah, so the National Park and USGS scientists have been surveying the groves that burned, and so far they say there aren't enough living sequoia trees left to help reseed these groves and grow new trees. And the park managers are saying, look, this fire was started naturally, quote unquote, by lightning, but the conditions of the fire are unnatural because they were fueled by human-caused climate change and fire exclusion. So the park managers decided that they needed to go in and replant the trees in some of these groves. And they see this as a necessary restoration to correct the damage done by humans. And they see it as their duty to restore those natural conditions required under the Wilderness Act. Here's Christy Brigham. She's Chief of Resource Management and Science for Sequoia and Kings Canyon National Parks.
We made decisions that resulted in incineration of 1,000-year-old trees, and rather than just let them disappear, to plant seedlings and give those trees a chance to continue to adapt and grow and evolve in the face of climate changes that are going to occur in the next 100 to 1,000 years.
So you talk to these park managers who want to plant trees, but there are other people that are against that idea.
What's that?
Who are they and what do they have to say?
What about lesbian love?
I said I'd rather talk about her lesbian lover.
Who make sure that the federal government is adhering to the law of the Wilderness Act.
Does she
And
have
in
a
this case,
pecker?
Wilderness Watch believes
Or
that
does
the
she tie it
replanting
a
of
pecker?
giant sequoias goes against the Wilderness Act. They say this was a lightning caused, naturally started fire, and the park.
You know what's really
shouldn't be
funny
replanting.
is there was a they had a swimsuit on sale for transgender people at Target. It was been like a couple years ago, and they took it off because people were complaining.